Good afternoon, everyone. Thank you very much for joining us in the latest instalment of Stewarts Soundbites. I'm really delighted this afternoon that we're joined by Dr. Liz Iveson, who is a stroke and neurorehab consultant at Steps Rehabilitation in Sheffield. And Dr. Iveson has a background in elderly care medicine. So today we're talking about advances in neurorehabilitation and stroke specifically rehabilitation. Dr. Iveson, is it fair to say that there's a bit of a change in the way that stroke rehab is being approached with the new NICE guidelines that have recently been published? I think historically there's been sort of 3 to 6 months of rehabilitation that patients are provided with post-stroke, but potentially the ability to plateau is much wider than that. And the importance, if you could describe to us the importance of the intensity and timing of rehabilitation following a stroke.
Yeah, thanks, Alison. Yeah, there's a lot of change happening in the sort of world of stroke rehabilitation, and it's really, as a stroke consultant that's been involved with stroke patients for over 30 years, it's really refreshing to see. So as you've alluded to, the new NICE guidelines on stroke rehabilitation were published at the end of last year, after the last ones were published 10 years before, and there has been quite they're very challenging and really quite ambitious, and there's been there's evidence now that what we've all known really is that, you know, after stroke, the more rehab you can get, the better, really. But we now got some of the evidence to back this up. And this is really important based on the fact that there's been massive advances in acute stroke treatments and early detection of stroke. Patients are getting to hospital quicker after an ischemic, you know, with stroke symptoms. I think more people know what a stroke is now than certainly when I started many years ago. And people are getting to hospital, they're having the acute treatments, but along with an ageing population and an increase in high blood pressure, we are seeing a lot more patients that, so more people are surviving acute stroke now, but a consequence of that is we're seeing you know, more people with neurological impairments following stroke that need high quality stroke rehabilitation. And the NICE guidance has changed to recommend a minimum of 3 hours of rehabilitation a day for a minimum of 5 days a week, with a very big focus on needs-based rehabilitation, making it very individualised for the patient, and a focus on timing, sequencing, content of sessions. I think this is, as I say, it is ambitious, it is challenging. The current practice is inconsistent, and that's fair to say, and that was stated in the NICE guidelines as well. It is a bit of a postcode lottery. We do have early supported discharge teams, but the reality of the NHS at the moment, and with it chronically underfunding, is the fact that patients are maybe getting one session of rehabilitation a week, possibly virtual, which isn't enough. And certainly the evidence now that higher intensity rehabilitation delivered by a specialist team improves functional outcomes, quality of life, and reduces the need for carers, and is cost effective as well. So it's an interesting time.
No, absolutely. And is it fair to say that the sort of perception that you had 2 years to recover is perhaps now being reconsidered, and actually people are still making gains much beyond that 2-year?
Yeah, and I mean, you know, I've seen this many times over the years, and this is one of the, you know, the reasons that I love my job, because I've always felt, and many of my colleagues have always felt, that often it's the environment and the resource around that person that plateaus rather than the person. And we've all heard multiple times that people sort of no rehabilitation potential, or patients are told and are still told, but less so hopefully, that after 2 years there's this magic cut off and they won't improve. And certainly what I see in clinical practice, and the evidence backs this up, is that the most improvement generally, and the higher rate of improvement, is within the first 3 to 6 months following a stroke. Mm-hmm. And that really is the time that the high intensity rehabilitation and the sort of multidisciplinary team and holistic approach needs to, is really key. But then patients still improve for years after stroke. The rate of improvement is generally slower, but also there are often other factors that sort of come in which impact a patient's potential for recovery, which need actively managing. And this is really important. And quite often, certainly within the current provision, patients after stroke are discharged from statutory services usually around the 3 months mark, with maybe a 6 months or a year follow-up. But active management of fatigue following stroke, spasticity following stroke, making sure that the right equipment's provided, positioning, pain management are all incredibly key to help that person then be able to continue the rehabilitation. And certainly I've found quite often people plateau, but it's not necessarily because their neuroplasticity and their sort of regeneration and is plateauing so much. It's more the fact that other things are impacting on their ability to be able to do the rehabilitation.
What about psychological?
Really
sorry, Dr. Iveson, what about psychological support? Is that something that is missing from the NICE guidelines, or is there anything there in terms of supporting patients from a psychological basis?
Yeah, so reassuringly, it features really quite prominently within the NICE guidelines now. Psychological input generally is really under-resourced, and again, it's absolutely key. I mean, stroke is an absolutely devastating diagnosis to have, and it doesn't just impact that person, it impacts all the people around them as well. And in clinic, I often see people that have had very minor strokes that have made a pretty much full recovery, but the psychological impact of having a stroke or a TIA even is can have a massive impact on that person's quality of life. We know that following stroke, up to 50–60% of people have depression, and again that has a really negative effect on sleep and function and the ability to the quality of life. So psychological support is inconsistent, again, depending on where you are. It will become hopefully part of the multidisciplinary team, and it absolutely has to be. I think it is currently picked up by every member of the multidisciplinary team, but the NICE guidelines again put the emphasis on having early psychological support and picking up mood and anxiety and all the other factors. It also does touch on other therapies, which again are really good from a psychological perspective, such as music therapy, group therapies, group gait therapies and exercise therapy, and the importance of including families and carers and relatives within the rehabilitation process. And again, I think that really is a challenge, and it is a challenge. It just needs a real change of mentality, and I've never understood why carers and relatives aren't more involved in the rehabilitation process, but there is still, unfortunately, this sort of separation and this gap. But at the end of the day, when someone goes home, it's the relatives and that are expected then to know what to do, and having them involved at an early stage in following stroke is really important. And again, the NICE guidelines emphasises that, which is really reassuring to see, because it's something that I've always been a big advocate for, and think is absolutely key to improving someone's outcome, really, and general health.
Yeah, if you haven't got the family on board to support are much likely to do better, aren't they? I suppose there's not specific guidance though for supporting the family. I know at centres such as Steps, that's a big part, very much the family involvement, isn't it? And supporting the family as well with psychological support. But I'm guessing in the NHS that's more limited. There's not specific recommendations for families.
Yeah, no, it's not a specific recommendation, but I do think, you know, having, you know, it's very unknown when a relative has a stroke. It's scary, isn't it? And you want to do your best to try to support that person. But if you're involved at an early stage and are spoken to as part of the team, or if you don't want to be part of the team, you at least the communication is there throughout, then and you're able to ask questions. And I think you can have that psychological support as long as if you're included and you communicated well with. And also I think it is our role as you know, stroke consultants and you know, other members of the MDT to recognise care restraint and to really pick up when someone is struggling and try and signpost them to you know, the GP or some charities that can offer that support. And there are some really good charities around that do offer specific support for carers as well, and groups for carers of stroke patients or family members that patients have had a stroke. So there are resources out there, and again, it is a bit of a it's not that widely signposted, but since the introduction of Zoom meetings like this and you know, video calls, the access for support is much more readily available, and at times that are feasible as well. So I think as long as people recognise it and pick it up and you know, just encourage that you know, the people surrounding the person with the stroke to have some support, I think it is there. And at Steps, certainly there's a lot of just getting the family in to help and talking to the family members, and just bringing the anxiety levels down from 100 down to, you know, try and reduce the anxiety a little bit, which is a lot of what I do quite often, is just talk to people.
Sure. Dr. Iveson, can you talk a little bit about the advances, some of the newer technologies that are mentioned in the NICE guidelines, and some of the other technologies? I think things like robotic technology has been introduced for stroke rehabilitation.
Yeah, so yeah, there's quite a lot sort of on the horizon. Many of them are still in the phase of the clinical trials, but what's coming out of the clinical trials at the moment is potentially quite exciting and positive. There's some quite promising results suggesting that some of these new technologies could lead to better functional outcomes, but they're not readily available yet. But the things that are more readily available, which help alongside traditional therapies. So when I say traditional therapies, I'm talking physiotherapy, occupational therapy, movement therapy. Some of the newer things which are mentioned in the NICE guidelines, I think, like the emphasis on mirror therapy, which has been around for a long time, but again, we have more evidence that actually can help sort of with neuroplasticity and fooling the brain that arm is starting to work. So you get the outcomes are quite promising with that. Robotics and use of robotic arms and the use of virtual reality again is really quite exciting, and a lot of it you can deliver more repetitions in a quite short space of time using robotic therapy. It doesn't replace physiotherapy. You still need a trained professional next to you to do it. But the thing that I think is a massive benefit is it engages the patient. It makes them want to do it. It's fun, you know, and also you can do really quite specific functional activities with some of the virtual reality and robotic therapy, you know, such as practicing pouring milk into a cup, you know, for tea, or holding a kettle, or you know, there's a lot of them that now use gaming and you know, tennis and lots of different games to really give you that sort of endorphin boost, but also I think it encourages people to do the exercises and the rehabilitation. because it can get very monotonous. If you're wanting someone to do up to 3 hours a day, 5 days a week, and some of my patients are incredibly motivated and they would naturally jump into it feet first, but a lot of patients are tired, they're achy, they're uncomfortable, they're still trying to come to terms with the fact they've had a stroke, and actually just doing something a bit fun and potentially functional, and so people can see why they're doing things. I think that really is a real plus of these types of therapies, as well as the psychological benefits as well. So you that within the NHS there are units that do have some of the robotic therapies. They're not formally recommended in the NICE guidelines at the moment, because we need a lot more evidence to collect more evidence for it. And at Steps, we have got a lot of the robotic. We're very lucky that they have got quite a lot of a varied range of equipment to try to to keep up with the progressing in technology. And what we are quite involved in as well is trying to help write protocols for how to use them, what seems to work, and try to help with collecting some of the evidence that is needed. But that they are, the use of robotics and virtual reality and gaming, I think, is definitely going to be embedded in the future of stroke and rehab in general.
And presumably patients can relatively easily get the virtual reality. It's probably not that robotics, I'm sure, are quite expensive, but the virtual reality that they're using in rehab centres, they could then use at home, could they?
Yeah, I mean, you can. So the virtual reality is again, it's the evidence for the use for ones that use at home again is not as readily available. But some of the virtual reality technology is very good for pain management, for example, and the psychological aspects. And working, you would still need a physiotherapy or an occupational therapist to help instigate some of these. Some of the robotic therapies, for example, the Sabreflex and the robotic hand, though, are used widely within the community and are funded within the NHS. So they are still available. Some of the sort of singing and dancing, full costumes, and things that require a lot of support from 2 or 3 therapists are not, but there are still quite a few things that are transferable into the community, and that is one of the keys as well, is for consistency and longevity of all of this, is to try to improve the amount that is available that can be used within the community.
Absolutely. And just finally, Dr. Iveson, we obviously spoke about the fact it's a bit of a postcode lottery, how much stroke rehabilitation patients receive. Centres like Steps are absolutely excellent and obviously provide that holistic approach to rehabilitation, but often funding them is difficult, and there may be a perception that most people have got a personal injury claim that are going to these centres. But can you talk about other ways in which some of the patients you've supported at Steps have been able to fund a placement there?
Yeah, so when we're talking about Steps, for those that don't know, it's an inpatient neurorehabilitation unit, and it offers basically everything under one roof. So it's, it has a wide range of therapies, but also a lot of the alternate therapies. And the biggest proportion of funding patients are stroke patients. And that's also what I see in my clinic at the Nuffield, is that, again, people with strokes are usually self-funding. But there are other options to try to get that sort of intensive burst of rehabilitation. So quite a lot of insurance companies now will cover outpatient therapy, but also will cover a short stay of inpatient therapy. So and usually it's a defined time of, I think it's 6 to 10 weeks, but that is they will fund that. So if you have insurance, medical insurance, that's one way people get funded. The other is certainly for the more severe end of stroke patients, and particularly some of the younger patients that have had really quite severe strokes. then applying to the individual funding request. We have quite a few of those patients in steps as well, who are funded directly through the NHS. We have a few patients that have clinical negligence claims through strokes, who are funded, and also critical illness cover, and patients often pay, you know, for that through various insurance policies that they have as well. So there are quite a few of different funding streams that enables people to access the you know, more intensive rehabilitation. I think the other thing really just to point out as well is, I think historically there has been a bit of an impression that if you access rehabilitation, so you know, you pay for a private neurophysio, or you're wanting to top up your rehabilitation, then your NHS, what you're getting from the NHS will then stop, and you can't do both. And I think, you know, that is something that we really need to stop this sort of perception that it's one or the other. And I think one of the challenges and one of the things that I really promote is trying to work as jointly together, and you know, what the NHS provides is usually a high quality, and it's usually good. There's just not enough of it, and the reality of it is it you know, there isn't. But I you know, I have patients that maybe get one physio session a week, but would really like 3. So topping that up with them paying for 2 extra sessions from a private neurophysio, for example, is a good idea. But it's I think there is this reluctance sometimes that they would then just not have the rest of the NHS care, which isn't true. And I also, again, from an inpatient perspective, it is really key. And one thing that Steps is very good at as well is that transition back into the community. So it's fine, you know, you come into Steps, you have a massive intensive boost, you know, you have lots of therapies, you're in a very, very supported environment. But then it's what next? And that transition into the community, making sure that the right support's there, that the patient and the relatives are all really empowered and informed to know what's available. The use of the charitable sector, I think, is really key. So the third sector have got a lot of really good practice, really positive people within there that can offer a lot of support, which we don't really often talk about so much. And also helping those patients access the statutory services alongside maybe topping up what they can, is really important for that transition going forward. I see it's not a particularly good business model, but I do private spasticity management within my company, within my clinic at the Nuffield in York, and a lot of my time patients come to me because the waiting list for the NHS spasticity can be, you know, a year sometimes. So I often see them justify why, you know, they need the spasticity managed with botulinum toxin, refer them back to the GP to say, right, come on, put them on the list, and then they come and see me, pay privately themselves until they're then picked up by the NHS, which I think, you know, and that's what, you know, I think it's working together really and trying to use resources in the best way possible.
Absolutely. Well, thank you, Dr. Ives. I think we could talk for a lot longer. It's really interesting to hear about the new advances and hopefully a positive change in stroke rehabilitation as well. You mentioned some of the charities. I think we can put some links to those when we post the recording of this, so if anyone wants to look into those charities. But thank you ever so much, Dr. Ives, and really appreciate your time this afternoon.
Okay, thanks.
Thank you. Bye-bye.